Hello again, students. How's everyone doing? Welcome back to another class on the VLP network. As always, I'm your instructor, Holland. It is good to be back. I know it's been a little while since I've dropped a video. As I've said in my previous videos, this isn't my full-time job and I have many things going on in the background, so I apologize, but I'm doing the best I can. I want to take a quick note and say that we've reached 300 subscribers, which is amazing. I had no idea that over 300 people were going to be interested in my videos. So let's keep it going, and I hope to continue to create good content for you guys so I can educate the masses on how to be a better prepared citizen for everyday life. And with that being said, we're getting into a very different topic for today's video. If you have been a subscriber of mine from the very beginning, then you know that a lot of my videos focus on sort of the self-defense aspect of preparation rather than other generalized preparation ideas. And that's mostly because that's the thing I have the most experience with and the thing that I would consider myself a primary expert in. However, from my experience in the military as being an EP agent, going through EMT school, and now also going through the process of becoming a police officer, I've learned many things over the years. And one of the things that I think that we're going to hit on today that I think should have been hit on a while ago, but I had other videos I wanted to do, is kind of the exact opposite of the violence aspect, more so the caretaker and medical aspect side of preparation. This is something that a lot of preppers don't really focus on, in my opinion. That's because they kind of get focused on sort of the John Wayne attack with violence when violence is presented to you type of mentality. And while that is important, a lot of the time we have to remember that a person who's supposed to be prepared is supposed to be prepared for all situations. You don't want to be a jack of a single trade or a jack of one or two trades. You want to be excellent at everything, so that way if you're presented with a situation, you know what to do. And so that's what we're going to focus on today. Being a prepared individual means not only being able to protect yourself and other innocents from evil, but also primarily being able to render aid to those individuals if they need it. Now, just a quick disclaimer, I'm not saying that this video alone is going to replace any sort of hands-on training that you might receive from a civilian TECC class or something of that nature. You absolutely need to go to these classes, and they are plenty available to the general public. Go ahead and just do a quick Google search, you will find them in your area. Also, I just want to make it clear, I am certified to talk about these things. I graduated EMT school. Here is my EMT certification. This comes from the Idaho Medical Academy, which I graduated from all the way back in April of 2022. I was also TECC certified for quite a long time when I became an instructor down in Pacific West Academy, which is the EP Academy I often talk about, where I was instructing students in basic TECC. And so this is something that I feel like I'm able to talk about and at least give you the basics. And that's the last point I want to make before we actually get into class today. I'm going to be keeping things quite basic, because if you have experience in this sort of thing already, then I'm trying to dumb it down for individuals that have little to no expertise or understanding of any of these things, which is kind of the way that my channel works. I cater more so to the generalized individual who doesn't have a whole lot of experience or really anything, and that's what my primary audience that I cater to is. So if you are experiencing this sort of thing, absolutely feel free to leave your knowledge down below as well. We can all learn something from other individuals. So with that being said, students, if you have nothing more for me, I have nothing for you. Let's have a seat and let's prepare to be better medically trained individuals in case we need to take care of ourselves, our families, or innocents during a situation we may find ourselves in. Let class begin. Okay, students, before we actually get into the meat and potatoes of the class, I'm going to briefly explain what TECC is for those who are uninitiated. TECC stands for Tactical Emergency Casualty Care. Essentially, it is the civilian version of TECC, which is the military's version of, let's say, a CLS course or a Combat Lifesaver course. When I was in the military, I'm sure there's other veterans that are going to comment on this as well. Almost everyone who is in a combat MOS or an MOS that sees some type of combat gets trained in CLS, Combat Lifesaver course. We deal everything from basic bleeding control to sucking chest wounds if you have to end up patching somebody up who has a bullet hole or a stab wound. And so if you have done a CLS or a Tactical Combat Casualty Care course, TECC is going to be very similar. Primary difference between TECC and TCCC is that TECC is geared more towards civilian use rather than a soldier or a Marine who is over in a combat theater. So there's going to be some slight variations on very small basic things. Things like gain fire superiority. Well, you know, in a civilian area, are we really going to need to gain fire superiority? If we're dealing with an active shooter, maybe. But generally speaking, we're not going to be doing things like creating casualty collection points or keeping security posted. We're going to be doing things a little bit differently as a civilian. Now, with that being said, the care portion and how we actually go about treating these wounds and treating individuals who are injured is going to relatively remain the same. So with that breakdown and understanding of what TECC is, let's go into the basics. And I'm going to break it down for you very, very, very Barney Cookie Monster style, as we said in the Marine Corps, so that way everyone is going to have a better idea of how to approach this in their own lives. So if you were looking at the words of the acronym in that transition PMARCHP and have absolutely no idea what the hell it means, that's what I'm here for, guys. So that acronym that was just flashed on screen, PMARCHP, is the acronym that you're going to need to memorize over and over and over and over again. And that is because that acronym, PMARCHP, is the one that's going to tell you exactly what to do and in the order to do it when you come upon an individual who needs some sort of emergency care. When I was in EMT school, we broke it down even more basic, which was the ABCs, 1, 2, 3s, airway, breathing, circulation, etc., etc. PMARCHP is a little bit different. It goes into a little bit more detail and we handle things a little bit differently, but for the most part, it's actually relatively very, very similar. I'm going to go over what every single one of these letters stands for, and I'm going to go into detail. So have a seat and listen up. Okay, the first P, patient provider safety. In EMT school, we used to call this jazz hands, okay? Making sure that your PPE, your primary protective equipment, is on, things like gloves and mask, and also making sure that the scene is safe. BSI, is the scene safe? And to which point the instructor would go, yes, the scene is safe, go. But it's pretty much the same exact thing in TECC, patient provider safety. First of all, you have to make sure that the generalized area where the incident occurred and the patient is in is safe to approach, so that way you don't also become a casualty. You are not going to be able to help anybody if now you are also the one that's bleeding out on the side of the road next to the guy who's originally gotten shot. Now, this is actually a really difficult thing for people who have a protective type of mentality to do, not rush into a situation because they see that people need help or they see that they're needed and they immediately want to rush into it and help people. That was kind of my problem when I started EMT school. But you have to have a higher thought process when going into these situations and ensuring that you yourself are not going to become a casualty when you're going and you're helping somebody, because you're not helping anybody at that point and you're also putting a burden on the other medical providers that are going to come. Whereas before it might have been only 1 or 2 casualties, now they got to deal with 3. So again, just make sure the area is safe. This could mean anything from very basic hazards, environmental hazards like downed electrical lines, inclement weather, combustible devices, fires, anything that could cause harm to you while you go in and provide the patient care. Or in, let's say, a much more serious situation like a mass shooting, making sure that the individual who is doing the shooting, the enemy or the active shooter, has either been neutralized or arrested or something, so that way you don't go in to help this person who's been shot and you yourself also get shot. It sounds really dumb and really basic, but seriously, this is a problem that a lot of people have. They want to rush in and they want to help, and that's good on them, but you aren't helping anybody and you're only causing more issues for the first responders by you yourself becoming one of those casualties. And it's going to sound really, really messed up, guys, but if the situation is so unsafe that you yourself cannot go in and actually provide care without becoming a casualty, it sounds bad, but in some cases, you got to let that patient go. Because again, and I'm going to reiterate this, even though it sucks, you're not helping anybody by becoming a casualty yourself. Now, if the situation is safe enough and you can go inside, that means also providing a safe area for the patient. If the situation is safe enough, generalized, but it could deteriorate, let's say that there's a storm coming, or let's say that there's a fire that's small and it could get bigger because there's an accelerant nearby, moving that patient to a safer area, as long as that patient is not too messed up or moving them is not going to kill them immediately. However, if the situation is deteriorating quickly and it's going to become an unsafe situation very quickly, we were taught in EMT school to get that patient out of there, and if you end up hurting them even worse in the process, hey, at least they're still alive and you can still render some care, as opposed to both of you dying because you decided to render care in an area that was quickly becoming unsafe. So, first P, patient provider safety. Make sure that the situation is safe. If you can make it safe by doing so. If there's an active shooter, that means neutralizing the threat. or just generally speaking, taking care of whatever threat there is, and then providing yourself and the patient with a safe environment so you can treat them. And if there's no way for you to make the situation safe, not putting yourself in unnecessary danger. Okay, second letter, M, stands for massive hemorrhaging. Pretty much if the dude is suffering from a bleed and the bleed is severe enough to where it's going to kill him, you need to stop the bleeding. Now there are actually two different types of bleeds. There are venous bleeds and there are arterial bleeds, and knowing the difference between the two is very important. Venous bleeds tend to be more constant in their flow, and they also tend to be darker in color, the blood. Whereas arterial bleeds tend to spurt along with the heart rate, and you'll also notice that the color of the arterial blood is going to be brighter in color, bright red. And while both are very dangerous, arterial bleeds absolutely are the ones that we need to focus on the most. Now, most people know that in order to stop a bleed, you're going to have to put pressure on the wound, but sometimes, depending on the severity of the bleed, pressure isn't going to be enough. It's for this reason that one of the primary things that we were taught in both TECC, CLS, and in EMT school, as a matter of fact, is the use of a tourniquet. It is a very, very common misconception that tourniquets are going to cause severe damage to the limb that it is put on. It's something that was occurring way back in the 70s and 80s when tourniquets were first really sort of thought about being used as a constant thing for medical care. And people were saying, oh, if you leave a tourniquet too long, you're gonna cause the limb to die and it's gonna need to be amputated and all sorts of crazy stuff. It's actually not true at all. As a matter of fact, proper tourniquet application can almost always stop the bleeding and save somebody's life in the limb, as long as they're getting to urgent care as quickly as possible. The limb can almost always be saved. As a matter of fact, tourniquet use has become so popular that that's one of the first things we were taught to put on in the case of a massive hemorrhage that we can't stop. If it's a limb hemorrhage, put a tourniquet on. So proper tourniquet application goes as follows. You want to take the tourniquet and you want to place it 2 to 3 inches above where the wound is. So let's say I got cut here and my radial artery is severed and I'm bleeding profusely out of my wrist. I want to make sure that the tourniquet application is actually a little bit farther up, right about here. If for whatever reason that original tourniquet isn't stopping the bleed, there is a technique that is called kissing tourniquets, and kissing tourniquets is where you take one tourniquet, put it right up against the secondary tourniquet. You don't take the original tourniquet off because you're just going to cause a massive backflow of blood to start pouring out of the wound. It's going to make things worse. As long as you can get that secondary kissing tourniquet above the original, if you have to put it below, then so be it. It's the best you can do, but you kind of want to get it above the original tourniquet. Once the tourniquets are applied, you're not just going to want to leave the wound open sitting there. We're going to want to take our combat gauze or our quick clot, put it on top, and then take an Israeli bandage or an H bandage or a pressure dressing and then wrap it around, so that way there's good pressure and good dressings on top of that wound. And last but not least, you want to ensure that you write on the tourniquet the time of application, so that way when the patient does get to advanced care, the doctors and the surgeons and the nurses are going to be able to tell, okay, well, this person has had a tourniquet on their limb for the last hour or so. And so that way they can go about the process of taking it off and figuring out what to do with the limb in a much easier fashion. Now, if the bleeding is occurring to somewhere other than the limbs, let's say the bleeding is occurring from a penetrating trauma to what we call the container, which is the chest or the abdominal section, we go about it a little bit differently. Because there are lungs inside of our chest, we are going to have to possibly deal with a thing called a pneumothorax. I'll get into that later. But because of the nature of a pneumothorax, we want to ensure that we create a good solid seal on that open chest wound, and so we should take what's called an occlusive dressing and put it on top. I was taught in EMT school by one of my paramedic instructors that he even puts occlusive dressings even when it's an abdominal wound and such. But I was taught in TECC that if you're going to create any sort of bleeding control to the chest area, you're going to also want to pack gauze inside. They would literally have us take gauze and just finger gauze deep into this dude's wounds in order to create a packed seal. And then once there was no more room left and there was gauze coming out, that's when you put your pressure dressing on top. However, I should stress that anything to the upper chest that might be affecting the lungs, you're going to think about a sucking chest wound and a possible pneumothorax situation, and so you're going to want to put an occlusive dressing on top. If it's the neck or whatever, again, same thing. You're going to want to take gauze and you're going to want to shove it up inside, and you're going to want to try and put as much pressure in there as you can to try and control the bleeding. Anything to the carotid arteries or anything of that nature is going to be a situation where you're really not going to be able to do much, but we can try our best with what we have. And again, I don't know why I feel like I need to say this. You don't tourniquet the neck. There are people that were both in EMT school and in the military who asked the dumbass question, do I tourniquet the neck if he's got a carotid bleed? No. You know what? Fine. Go for it and just see what happens. Other than that, if the bleed isn't so severe that it's going to cause the patient to expire, we actually tend to leave bleeding alone. Notice the M stands for massive hemorrhage. The hemorrhage is so big that it's going to cause death more so than the other things down the list. If the hemorrhaging isn't as severe, we move on to the next one, and that's what we're going to do now. So the A in PMARCHP stands for airway. Basically, is their airway occluded? Meaning, is the airway blocked? Are they capable of using their airway to breathe on their own? If they aren't, then you're going to need to figure out a way to open their airway. Primary way that everybody learns in CPR class to open up an airway is the head tilt chin lift maneuver. And this is still taught in EMT school as the primary method of opening up a patient's airway in order to ensure that their airway isn't occluded. The only time that we do not use the head tilt chin lift maneuver is if the patient could potentially be suffering from some sort of spinal injury, some sort of cervical injury. If you tilt their head, you're going to aggravate that cervical injury and potentially cause even more damage. And so in that situation, we use method number 2, which is what we called in EMT school the jaw thrust maneuver. Pretty much using the jaw thrust maneuver, you take your 4 fingers, you put it underneath their jaw here, and you pull, and that pulling motion will force their jaw up and open their airway. Obviously, it's difficult for me to show you on a video. This is why you need to go and you need to learn these things firsthand. But just be aware that if they have a cervical injury or you suspect a cervical injury, you do not want to perform a head tilt chin lift maneuver. There are other ways to open up the airway, things that you learn in EMT school like naso and oropharyngeals. I'm not going to talk about those at all because I don't want you guys to even try and apply those. If you want to learn those things, go to EMT school. I did it and it was $1,600. It's a lot of money, but hey, I did it because I wanted to become more skilled as a prepared person. If there is a choking hazard and the patient's airway is occluded that way, we never perform blind finger sweeps anymore because in a choking situation, they might possibly bite down and cause you injury. So instead, you perform a Heimlich maneuver, or if they are unconscious, you go right into chest compressions for CPR. A lot of the time, the compressions on the chest will force the food or the object out. If it's an infant, obviously we use our 2 fingers, and we also provide back blows to the baby. These are things you learn in basic CPR class, which in my opinion, everybody needs to go to. I'm not going to hit on them too much because again, learn them in basic CPR. How to perform child CPR and how to perform child back blows is essential if you're going to be working alongside children or just in general preparation in life. Once the airway is clear, if they are conscious, they should be able to breathe on their own. And if they're unconscious and they have no pulse, you go right to CPR and chest compressions. But the A and PMARCHP, airway, make sure that their airway is open and they are able to breathe properly. A lot of the time, the way that we would go through A in EMT school is, hey, are they talking to me? Are they screaming out in pain? If they are, their airway isn't occluded. So that's one of the ways that you can quickly gloss over that because you're going to be going through these things very quickly in an actual situation. Is the person talking? Is the person screaming out in pain? If they are, then their airway isn't occluded and you can move on to the next one, which is going to be R. If the patient is unconscious and you're trying to see if their airway is open, look at their chest. Do they have proper chest rise and fall? Listen. We would always take our ear, we'd put it to their mouth with our eyes facing towards their chest. Can you hear them breathing? Can you see them breathing? If you can, their airway's open. And at that point, you can move on, which is what we're going to do now. Okay, we're halfway there. R stands for respirations. Respirations pretty much is their breathing. What is their breathing like? A lot of people get this confused with the A for airway. They're not the same. Airway will affect respirations. If their airway is blocked, they're obviously not going to have respirations. But if their airway isn't blocked and they're having respirations, the quality and the rate and the rhythm of their respirations is going to be indicative of whatever's wrong with them. I'm not going to get too far into the weeds with this because I could go over Kussmaul respirations and Shane Stokes breaths and things of that nature. It'll be a freaking hour-long video. Essentially, the 3 things you need to look at for in respirations are the rate, the rhythm, and the quality. Think about that again. Repeat it. RRQ, rate, rhythm, quality. The rate, are they breathing at a proper rate? A standard human being, when they're rested, will breathe between 12 to 20 breaths per minute. Obviously, this will increase if they're in an adrenalized situation, but if it decreases and it's below that, then that could be a severe issue. The rhythm, what is the rhythm of their breaths? Are they breathing rapidly and then having apneic periods where they aren't breathing at all? Is it kind of randomized and it doesn't have a proper rhythm to it? If that's the case, that's an issue. And then the quality of their breaths. Are they able to take full-blown deep breaths, or are they only able to breathe very shallowly? Are you hearing different noises every time they breathe? Are you hearing wheezing, or are you hearing like a whistling type of noise? If you are, then that could also be indicative of airway swelling from, let's say, like an allergic reaction. Someone got stung by a bee and now their throat is swelling up and they need to get injected with epinephrine. Something of that nature. That's going to give you an idea of what's going on, so you can either take care of it yourself or you can relay that up to the 911 operator so the first responders know what they're dealing with when they get there. Because sometimes, guys, even when we're in a situation and we can't provide care, let's say we don't have the resources to provide care, we can at least, if we know what we're doing and we know what's going on with the patient, we can relay that up to higher care, so that way the first responders, when they get there, aren't going to have to really diagnose them themselves. They're still going to do a diagnosis because that's their job, but they're going to be able to have a better idea of what they're getting into so they can better prepare while they're on the way there. If the person isn't breathing at all and their airway is in fact clear because you did a head tilt chin lift, you looked inside, you see that their airway is clear for the most part from what you can see, that's when we have to do rescue breaths. The standard thing for CPR is 30 compressions to 2 rescue breaths. You do that 4 to 5 times and then you recheck for a pulse. If they have a pulse, you stop CPR, and if they're breathing, you stop giving them rescue breaths. If they don't have a pulse and they're not breathing, you continue on. You can give rescue breaths through multiple ways. Obviously, they have face masks that you can put on so you can give somebody mouth-to-mouth resuscitation. Or we also have these things called BVMs, which is a mask where you can put on with an actual inflatable squishy thing where you grab it and you press in order to actually force air into the individual's lungs. You do that when you have their head tilted or you have their jaw thrusted, so that way their airway is open, and then you put breaths in. Not everyone carries a BVM in their vehicle, and not everyone knows how to use it. It's very easy to learn. You learn it in EMT school. It's a very basic thing, giving standard ventilated breaths for somebody who can't breathe on their own. It's something that I recommend you guys check out. But that's all we really need to know about this particular one for respirations. What's the rate, rhythm, and quality of the respirations like? And then based upon those things, we can figure out a better idea of what's going on with them. Okay, let's move on. Okay, third from the bottom, we are on circulation, or C. Circulation is another one that gets confused with massive hemorrhaging, just like respirations and airway do with each other. They're not the same. Someone could not be bleeding at all, either externally or internally, and they might not have any circulation going throughout their body. The best way to check for a proper circulation is obviously through a pulse, and we check this through either carotid pulse, radial pulse, brachial pulse, femoral pulse. We can do it on the foot with a dorsalis pedis pulse. There's multiple different ways we can check for a pulse, but the 2 standardized ways are obviously carotid or radial. When checking for a pulse, do not use your thumb. Your thumb actually has a slight pulse to it, and that can oftentimes screw up the way that you feel it. So you use your first 2 fingers, you reach inside on the thumb side, and you feel the pulse that way. And just like with respirations, we are looking for the RRQ of circulation, the rate, the rhythm, and quality of the pulse. A standard healthy pulse rate for a human being is 60 to 100 beats per minute. We do this by feeling the pulse, and then we count in our heads. We usually go for 60 seconds, or to make it easier, the way I was taught in EMT school is you count for 15 seconds and then you multiply that by 4. So let's say, you get a dozen beats in those 15 seconds, you take a dozen, you multiply it by 4, and that is the pulse rate. If they have a higher pulse rate than that or a lower pulse rate than that, that can be indicative of certain things. For example, in the early stages of shock, let's say compensated shock, when the body is still able to compensate for blood loss, let's say because of massive hemorrhaging, the heart rate is going to be increased because the body is trying to make up for the amount of blood that is lost. However, in the later stages of shock, let's say we're going into decompensated shock where the body can't compensate anymore, the pulse rate is going to become lower because it's just losing strength, it's losing blood pressure. We also have to be checking for the rhythm. Is the pulse bounding? Is it a bounding pulse? If it's a bounding pulse, then that can be indicative of some sort of heart issue, some sort of fibrillation of some kind. And then again, the quality, is their pulse thready? Is it weak? Are you barely able to feel it? These are things that first responders need to know, and things that you need to know in order to understand just what the person's current situation is. If they have a very weak, thready pulse, you know something's very, very wrong. And of course, if they are pulseless, then they're going to need to be defibrillated. And so at that point in time, while you're performing CPR to try and get the circulation throughout their body, obviously have somebody, if there's a bystander that can help you, go get an AED so you can try and defibrillate them back into life. The primary thing we need to understand from a TECC standpoint is, does this person have a pulse? If they do, you do not need to perform CPR. If they don't, CPR, chest compressions, AED, defibrillate them. If they do have a pulse, monitor and figure out the rate, rhythm, and quality of that pulse, so that way you can give that information to the first responders, so that way when they come in, they know what they're dealing with. Two more guys, let's talk about them. Second to last one, the H and PMARCHP, head trauma and hypothermia. Let's discuss head trauma first. Head trauma is a vast thing that we could talk about, because the head is not just the brain, it's the eyes, it's facial trauma, things of that nature. Probably one of the biggest things that we have to be worried about, though, is a thing called ICP, or increased intracranial pressure. When looking for somebody who has had head trauma, one of the things that we almost always do is we look into the ears really quickly. We're looking for blood, or we're looking for clear fluid that is called CSF, or cerebral spinal fluid. Cerebral spinal fluid is this fluid that kind of acts as a sort of liquid cushion for your brain. And when there is severe increased intracranial pressure and your brain is swelling, it sort of forces that out of the orifices of the head, and so oftentimes we can see blood or CSF leaking out of the ears. If that is the case and you see that, there unfortunately isn't a whole lot you can do, with the exception of providing them supplementary oxygen, monitoring them, treating for shock, and then just letting the first responders know, because they need to get that person to the hospital very quickly for a surgical procedure. If there is trauma to the eyes, one of the primary things that we always taught individuals, and something I learned in EMT school, is let's say there's trauma to a singular eye, you want to bandage that eye, but then also bandage the other eye, because eyes move in conjunction with each other. So if one eye is left open and they have a tendency to look around, it could cause damage to the other eye. So you want to cover both of them, so that way they don't have the desire to look around everywhere. If you sort of cover their eyes, they're not going to have that desire, so it's going to cause the damaged eye to move less, therefore reducing the amount of damage that can be caused from eye movement. Bleeding in the face. Bleeding usually is pretty heavy in the facial area, just because there's a lot of capillaries and the skin is very thin, so it can get cut very easily. Usually this bleeding is not severe in nature. You can treat that as secondary wounds later on when they've been stabilized. Head trauma can also mean things like neck trauma, putting them in a C collar because there's some sort of issue with their spine. You want to make sure that you keep their head in a neutral inline position, so that just means supporting their head, keeping it straight just like my neck is now, not moving it any sort of way, not having their head bent in any sort of strange way, just keeping their head in a neutral inline position and holding it there until someone else comes along to assist you or first responders show up. But again, probably the biggest thing that everyone gets scared about or everyone's freaking out about is increased intracranial pressure. One of the ways that we can look at a patient and tell when there is a possibility of increased ICP is a thing called Cushing's triad. Cushing's triad is defined by 3 specific things, and when you see them occurring in a patient, you can be pretty aware that there might be some ICP, or there probably is some increased ICP. These 3 things are going to be an increased blood pressure, even though we're not going to probably have the gear on us to measure blood pressure, an increased blood pressure, a decreased pulse rate, and abnormal respirations, usually decreased respirations. So if you notice that their heart rate, their pulse, and their respirations are low and becoming lower and weaker, and there is a reason to believe that there is head trauma, maybe they fell and hit their head or something of that nature, or somebody smacked them in the head with an object or whatever, you can have a reasonable suspicion that there is increased ICP. And lastly, we'll talk about hypothermia. That's the second part of the H in the last portion of PMARCHP. And it sounds stupid, but hypothermia is actually one of the things that you really need to watch out for when you're caring for a patient in the act of caring for them. The reason is because, think of it like this: if the patient is lying down on the ground and it's cool out, that pavement or that wherever they're laying is going to be sucking the body heat out of them, and especially if they are uncovered, they're in a colder environment, there is wind chill, they're sweaty, or they've lost a lot of blood, and so the volume of their blood is gone from their body. All of these things are going to add to hypothermia. Hypothermia is actually so much of a danger that when you're treating for shock, one of the primary things you do is cover the patient with a blanket to stop them from getting cold. If the patient is wet, you can try, if you have some sort of towel or rag, and try and dab off the water from them. That is something that can help them be preventative of hypothermia. You can move them to an area that's warmer, move them to an area that's sheltered from the wind, or like I said, when treating for shock, just cover them with a blanket and keep them warm. It's pretty self-explanatory, but it's one of the last things people think about, and there have been issues sometimes with patients suffering from hypothermia, even though the original issues that they had got fixed. They started to succumb to hypothermia, which is a totally random thing. So head trauma, hypothermia. Let's move on and talk about the very last thing. So the last P in PMARCHP, the very ending one, is the one that is the least important, and that is pain management. I know that sounds cruel, guys, but honestly, managing the patient's pain is one of the last things you need to worry about. If they are in pain and they're freaking out, but they are stable, they're at least alive. It's also difficult for us as civilians in a TECC role to manage somebody's pain. You know, as an EMT, or more specifically as a paramedic, you can administer drugs and stuff like that in order to help manage their pain. As an EMT, we're only allowed to give out 7 different types of drugs, and most of the time, unless it's aspirin or something of that nature, they really don't deal with pain management a whole lot. If we're trying to give serious pain management, like hop them up on drugs, we actually have to have advanced care, a paramedic come and do that, because only paramedics go through pharmacology and everything. So us as civilians, we're not going to be able to pull out all the crazy drugs that paramedics have access to. So in this point in time, it's more so important to focus on something else, which is reassessment. Reassessment is ridiculously important, because if you have the guy stabilized and you're like, oh, I stabilized him, okay, I'm not going to pay attention to him anymore, something might actually end up going wrong medically or trauma-wise while they're lying there waiting for advanced care to come. And if you're not paying attention, that patient might succumb, or they might end up becoming worse. The way that we were taught was, if it's a trauma patient who is not very stable, you reassess every 5 minutes. If they are a somewhat stabilized patient, or you're confident that they are stable, you reassess every 15 minutes. Either way, pay attention. If you're trying to do triage and you're trying to treat multiple patients all at once, because you're the only one around that has some sort of medical expertise or knowledge or any sort of medical skills, and you need to try and help as many people as possible, do your absolute best to reassess. Once again, reassess critical patients every 5 minutes and non-critical patients every 15 minutes, and just make sure that their pulse is still good. Check their pulse, check their breathing, make sure that their airway is still not occluded, and just make sure that the tourniquets are actually working properly, they're actually not hemorrhaging again. Just make sure of all these things, and just kind of reassess their mindset, whether or not their level of consciousness is appropriate. Are they starting to fade in and out, or are they actually responsive and can intelligently respond to you whenever you ask them questions? Things of that nature, so that way you can monitor how the patient is while waiting for advanced care. And that is really it for the last P. Again, there's not a whole lot we can do for pain management. I'd say the most important thing to think about is also to reassess the patient every single time you have one, every 5 or 15 minutes, so that way you don't just let them kind of drift off into a worse state if something ends up going wrong. So students, in conclusion, PMARCHP, that is the primary thing that you need to be studying reverberating in your head over and over again, because that is when you come up to a situation where you're going to respond medically. If you're choosing to do it, that is the acronym that you're going to need to follow by the letter in order to go about triaging and taking care of a patient responsibly. Now, I should note two things, and the first is there's a lot of medical information that I can go over, but I'm not going to, because in all honesty, if I went over it, it would be multiple videos. It would be 3 months of EMT school crammed into videos, and I don't have the time for that. You don't have the time for that. If you really want to get into the nitty-gritty, take a professional class. This is just me giving out basic knowledge so that way you can kind of have an idea of what to expect and what to do in case you find yourself in a basic situation, or if you're the only one that's there, you have at least an idea and you're not just sitting there going, I don't know what to do, because that's the worst feeling in the world, being presented with a situation and having zero idea at all how to handle it. And the second thing I want to make clear, this is no way me certifying you for anything. This is in no way me telling you how to perform specific medical procedures. The last thing I want to hear is, oh, well, Instructor Holland, I saw his YouTube video. That means I'm a certified TECC instructor. No, no. This is simply a knowledge classroom portion video. You're going to need to go and you're going to need to do actual hands-on practical application practice in order to better understand how to perform these procedures and how to do things like apply tourniquets and stop bleeding. And so what I think I'm going to do is, this is going to be part one in a two-part series, where this is going to be more of the classroom type portion. Then I'm going to make another video showing basic things like basic tourniquet application, pressure dressings and stuff like that. And I'm going to do that using my own gear. I have an EMT bag that I keep at home and in my truck, and so I have the things that I can use in order to show you. Because again, me just talking about it does not put it into perspective. You need to A, see how it's done, and B, do it yourself. However, I hope that the knowledge that I gave out in this video was at least substantial enough for you to feel just a little bit more comfortable about what to do in specific situations, and also just kind of open your mind to the medical aspect of things, because being a warrior is great and all, but we also have to be a compassionate warrior, where we eliminate the threat and we eliminate it wholeheartedly, but we are also there for the individuals and the innocents that need us. So students, I will eventually get to that part 2 video. It'll more than likely be my next video, but I promise there will be a secondary add-on to this video where I kind of go over those things practically. Keep an eye out for it. And as always, if I missed a few things, I'm sure I did because I was kind of glossing over a bunch of stuff. Feel free to leave it in the comments respectfully. Don't be a douchebag about it. Just leave it in the comments if you want to talk about some things that you might have experienced, some training that you received that might be different or also might be similar, things that we can do to help our community just be better prepared individuals. So students, if you have nothing left for me, I have nothing left for you for today's class. I hope you enjoyed today's class and hope you found it interesting and informative, and simultaneously I hope that you continue to watch my videos in the future. If you aren't subscribed, well, you know what to do. Remember students, victory loves preparation, so let's stay prepared, let's stay training, let's stay fit, and let's stay mentally sharp. Have a good one, guys. See you next time.